Good evening, everyone. Such a pleasure to be here. Welcome to the ASCO 2025 GI Oncology Now. It's such a treat and a pleasure to be here with my dear friends and colleagues, and we're really excited today to talk about some of the big updates that's happening in the GI oncology space at ASCO 2025. So without further ado, we'll just do some quick introductions and we'll get chatting. As mentioned, I'm Aparna Parikh. I'm a GI oncologist at Mass General Hospital. I'll start with you, Cathy.
Cathy Eng from Vanderbilt-Ingram Cancer Center.
Scott Kopetz, MD Anderson Cancer Center.
Stacey Cohen from Hutchinson Cancer Center in University of Washington.
Christine Parseghian, MD Anderson Cancer Center.
All right, so really exciting year. I think 2025 overall for us in colorectal cancer. We, I think, unfortunately have had many, many years where we haven't had a lot of options for our patients, particularly with metastatic disease. And I think over the last couple of years, I think the biomarker field has really exploded. And it's really exciting to see more and more options for our patients with metastatic colorectal cancer. I think just maybe let's just chat a little bit around just the role of biomarker testing and how folks are thinking about biomarker testing for their patients with colon cancer. Cathy, you want to start?
Sure. I would say that I think we would all agree that biomarker testing is critical in the treatment of all of our patients. Obviously, all patients should be tested for microsatellite instability, but also NGS testing or next generation sequencing is of key importance to help sequencing of treatment and trying to identify clinical trials and options for our patient population. And we're going to see some of that discussion later on today.
And Cathy or others, how are you testing? Tissue, blood? Are you testing?
I do both. I definitely do both, just in case.
Anyone only doing one, or no? And for like MSI high testing, for example, is it by NGS, or you're doing reflex, IHC, PCR, or Christine? What are you guys doing at MD Anderson?
Yeah, we'll do reflex, but then also we do have, the NGS panel that we have that kind of has all the MSI and all the,
So what's in the reflex panel?
Yeah, so we will do both because I think some of the discordance data really suggests that it's not a huge number, but there's some that sometimes the IHC is a little tricky to interpret.
It can be finicky,
yeah, it can be finicky, and especially those like PMS2 losses that are like isolated that you look at and you're like, I don't really know. So there's always that comforting confirmation that comes from getting an NGS panel where you see just a really high tumor mutation burden that makes you realize, okay, this is a real case.
Yeah, and it feels like in this day and age, like it's just a never miss event. Like it's the one thing you don't want to miss because we can cure our patients with stage 4 disease too.
And it's easy to do IHC in-house.
It is, yeah.
So, inexpensive.
Maybe just for a couple minutes before we actually move on to the different therapies. NCCN just recently, Stacey's on the panel and just recently updated the testing based on the GI ASCO data we saw for PI3 kinase mutations. And so
I didn't know that. Okay.
Yeah.
Okay, missed that.
Yeah.
I want an update.
So Aspirin.
Aspirin for all.
Aspirin for all. So it's interesting because I think we've been talking here largely around the assumption of stage 4 patients getting tested or patients with stage 4 disease, but I think the tides are turning a little bit and should we, what are the workflows that are going to be required now to start testing all patients? Some make the argument, aspirin's pretty benign, is it worth it? But I think we're moving to this era where all patients with colorectal cancer, I think, should be getting NGS testing. Any thoughts, Stacey? Or?
Yeah, I think it's something that we're definitely finding it's of increasing importance, and I feel like we've known this for a while, but we were a little lazy about it. We said, you could eventually get tested and you need to know it, but now I think, as you said, it's a never miss event, and we need to know the results now at diagnosis before we start treatment, and that really changes how we treat patients overall. So NGS will certainly be helpful if you're going to use PIK3CA to decide who's going to have aspirin. Thankfully, that would be more in the adjuvant setting, but I do think that this is sort of our new wave of testing.
And the question is, are we going to be using aspirin and a metastatic just on the basis of the adjuvant?
Well, that's an interesting thing you brought up, right? So I have a patient that had adjuvant therapy after her liver resection, but then had another recurrence, and then she has a known PIK3CA mutation, and she doesn't want any more chemotherapy. So she said, well, can we try it? I said, well, it's aspirin. So so we're trying it. It's anecdotal, but we'll see what happens.
Yeah,
I mean, the data's intriguing for the early stage setting.
It is. No, and I mean, I feel like in the old days, like it used to be aspirin for everyone, and then it went away. Like maybe we shouldn't be giving aspirin to everyone.
And then the dosing.
Dosing. So,
So are you guys going to do 160 though, or the 160 for 3 years, or are you going to do 81? Well,
Yeah, I mean, I think maybe in younger, I think in younger patients, or like no other, GI upset or tolerability issues, I think 160 is reasonable. And with a low threshold, if people are starting to get into some stomach issues and things, peeling back is sort of has been my take. I'm not sure if people agree or disagree.
I mean, I think the beauty of that study also is, there's all this metastatic, obviously biomarkers being so important now in the metastatic setting and the delay in time to acquisition of these. So now if we're testing all of these early stage, at least we'll have that data available, in the event, unfortunately, if they progress that way, we'll have the first line indication more kind of quickly ready to go. If they have a BRAF mutation or a G12C mutation or HER2 amplification, we'll be ready.
Yeah, I think Scott and I were chatting with a colleague yesterday, and he sort of made this analogy of, time to cath, right, for cardiac events, and should it be like time to test now as like a quality metric for the biomarker setting.